let's go ahead and talk about our next subject. And again, sorry for the poor acoustics. This room is just a really tough one to deal with, but it's what we got. Okay, I'm going to talk about hypertensive emergencies now. So in general, let me pose a question. In general, do we aggressively treat hypertension out in the field? No. So that's the first thing we need to remember. In general, we do not treat hypertension. There are lots of problems associated with aggressively treating hypertension. Specifically, okay, if I aggressively decrease the blood pressure, that can lead to end organ ischemia. Okay, and somebody who's hypertensive, their body may have compensated and adapted to having a higher than normal blood pressure, right? And so when we decrease that blood pressure, okay, if their body is, let's say they're at 160 over 100 and they've been that way for a year or more, okay, and then we come along and we drop it to 120 over 80 because that's normal, that looks better, what is going to happen to all of the vascular supply to all of those tissues that are used to those higher pressures? Yeah, you have just significantly compromised end organ perfusion, right? Those tissue level perfusion. So in general, we do not aggressively treat blood pressure. Okay, you guys okay with that? Now there are right hypertension. Yeah, we're talking about we do not aggressively treat hypertension. Yeah, hypertension. Right. We do not, right? In some cases, hypertension may actually be a compensatory mechanism to increase perfusion. For example, in brain-injured patients, in patients that have strokes, it is not uncommon for them to have a compensatory hypertension that develops. And as we'll learn about in neurology, right? Cerebral perfusion pressure is very important. It's a pressure that perfuses the brain. And when your intracranial pressure increases, that decreases the cerebral perfusion pressure. So one of the compensatory mechanisms to get that CPP back up is to have hypertension, right? To increase your mean arterial pressure. Okay, so there are lots of good reasons that we do not aggressively treat hypertension out in the field. Now, there are conditions, or there are two conditions where you have what's known as a severe elevation in blood pressure. And in general, we're looking at blood pressures that are significantly higher than about 150 over 105. Okay, 150 systolic, 105 diastolic. Generally, we're not even really worried until we get above that range. We're worried chronically, right? We're worried chronically. But when we talk about acute or emergency treatment, we don't really get concerned until we're there. Once we get significantly above that, okay, we have one of two conditions, one of two diagnoses, if you will. Okay, we have something known as hypertensive urgency. Okay. Hypertensive urgency is defined as a marked elevation in blood pressure. Okay. And here's the key thing though. The blood pressure is very high, but there is no or without evidence. Okay, without evidence of end organ damage. Okay, so you assess your patient, their blood pressure is very high, but there's no evidence that their organs are being damaged significantly. Okay, so their kidneys appear to be working, their liver appears to be working, their mental status is okay, they don't have any neurological issues. Okay, so they are in what we call hypertensive urgency. Okay, we need to deal with this, but we do not need to deal with this aggressively or acutely as paramedics. Does that make sense? However, there is something called a hypertensive emergency. This situation requires treatment. In a hypertensive emergency, it is a hypertensive urgency plus signs and symptoms of end organ damage. What kinds of things would tell us that we have end organ damage? Okay, maybe jaundice. So first of all, we'd have to have a markedly increased blood pressure. Would you guys all go on board with that? Okay, so that's what we see with hypertensive urgency. Okay, the next thing, okay, renal. Renal is a big one. Decreased urinary output is a big one. Okay, decreased urinary output. What is your normal urinary output? Say that again. In an adult patient, your normal urinary output, and this is a number that you'll want to know, is about 0.5 to 1 milliliter per kilogram per hour. That's normal. Or approximately 30 to 50 milliliters per hour. Okay? When you get below that, that means a couple of things. That means your kidneys are not being perfused, okay, i.e. there's low blood pressure, there's something blocking them, or you are so hypertensive that you have destroyed the normal anatomical functioning features of the nephrons, okay? So if you have a markedly elevated blood pressure and you have renal impairment, your urinary output is very low. Okay, that indicates a hypertensive emergency. If you have visual compromise, okay, so your patient is having visual issues, they're having hemorrhage, they're having retinal hemorrhage, okay, or they're having something called papilloedema. Papilloedema. In your intro to advanced care class, when you did your advanced patient assessment, this should have been something that you guys talked about. Your pupil assessment. It's called papilloedema. Hemorrhage. So, is that a familiar term with you guys, papilloedema?
The term's not, I don't know exactly.
Okay. So here when I get through this, maybe we will spend a couple of minutes talking about that. Did you guys, okay, when you do your eye exam, it's more than just, what do my pupils look like, right? I'm just looking at the pupils, right? It's a little more nuanced than that. And in the intro class, you should have talked about some of that nuance, looking at the pupils, the extraocular motions, looking for evidence of papilloedema, which can be very difficult with the tools that we commonly have available. But we can talk about that in a little more detail. Okay. The next major one is central nervous system impairment. Okay. So your patient develops a severe headache, confusion, and other neurological changes. Okay. But again, stroke can cause that, right? And stroke can cause hypertension as well, so it's a real sticky. Okay, so if you have all of these things going on, right, you have a constellation of these. Okay, you have a headache, you have neural impairment, you have renal impairment, okay, you have some visual changes, and you have this markedly elevated blood pressure. At that point, you have enough evidence to say what? We're dealing with a hypertensive emergency. You guys okay with that? What are some risk factors, if you had to guess, for developing a hypertensive emergency? What do you think number one is? Of a hypertensive emergency. Not risk factors, though, for causing this. Yeah, well, what's going to be number one? Number one. Number one on the list. What conditions causes? Number one. Yeah, what causes hypertensive emergencies? Number one on the list. Don't make it hard. Hypertension. If your patient has a history of hypertension, guess what? They're going to be at risk for hypertensive. Does that make sense? Yeah. All right. All right. Yeah. Oh, risk factor causing. Now, number two, uncontrolled. Uncontrolled hypertension. How about that, right? If you have hypertension that's not well controlled, you're going to be at higher risk. Okay, number three, if you abruptly stop your meds, right? If you're being treated for hypertension, you abruptly stop taking your meds, that's a recipe for hypertensive crisis. We occasionally see this down here, all right? Not only with compliance issues, but some people just simply can't afford or they don't have the resources to get their meds. And we occasionally see this in people that migrate across the border, that run out of meds or don't have access to their meds and then end up having an emergency out in the desert. Another condition that causes this is renal artery stenosis. Okay, if your patient has a history of renal artery stenosis, this wreaks havoc with your renin-angiotensin-aldosterone system. Put you at really high risk for this. And then I will just throw this in as something to think about, even though we're not really going to talk about it today, and that is toxemia of pregnancy, also known as preeclampsia and eclampsia. Yeah. Okay. That's treated a little different, though, than the standard run-of-the-mill hypertensive emergency. You guys okay there? Okay. So, let's say that you have all the risk, you have one of the risk factors, you have a markedly elevated blood pressure, and you have pretty good signs and symptoms of end organ compromise. So you have all three of those things, you put them together, and you can make a strong case for hypertensive emergency. Again, you have to be able to make a strong case for that, right? You've made a strong case. Can we then treat in that instance? Yes. Are we going to treat it aggressively? No. So let's talk about how we treat it. So, again, we only treat this if those three things are met. We have risk factors, right? We have signs and symptoms suggesting end organ dysfunction, and we have a markedly elevated blood pressure. So we have a hypertensive emergency on our hands. All right. How do we treat it? So we start just like every other patient, supportive care, right? Supportive care. How about that? Okay. The low-hanging fruit got picked, right? So, then what? A, B, C. So let's start with A and B. If your patient has dyspnea plus hypertensive emergency. What primary therapy do you think would be important? Okay. Okay. Okay, pulmonary edema could be a problem, may or may not exist. But what modality? It's one that you guys carry. Say it again. CPAP. Good. CPAP. Or if you have it, BiPAP. Bilevel positive airway pressure. Okay. So if somebody's having a hypertensive emergency with dyspnea, CPAP or BiPAP is indicated, right? And that makes sense because what's CPAP going to do to your preload? Decrease your preload, decrease cardiac output, might decrease blood pressure a little bit, right? So it might actually be helpful in that sense as well as helping with oxygenation. Okay, you guys okay with that? And then we get into pharmacology. And again, guys, this is not aggressive. We are not hanging a drip to aggressively decrease the blood pressure, okay? So here are our general guidelines. Our goal with a hypertensive emergency is to only decrease the blood pressure, so we're talking about the systolic and diastolic, by no more than 25% in the first 2 to 6 hours. Are you guys okay with that? Okay. That is as aggressive as you want to look at getting. Yeah, you can go less than that, but that is the goal. Over 6 hours, we decrease it by 25%, or we can, okay? Over 2 to 6 hours. 10 or 20 minutes. Not much, huh? Not much. This is over 2 to 6 hours that we're decreasing this. You may not see a huge decrease, okay? Which means that you need to do what to your vital signs? Close monitoring. Okay, I'm talking Q5 minute. Yeah, 3 to 5 minute blood pressure checks, right? Okay. So what kinds of medicine? So let's talk about choice of pharmacology. What can we choose? What should we use? There are two general classes, excuse me, okay? There are 2 general classes that are recommended. There are the nitrates. Okay, that's the first class. And there are beta blockers. Yeah, beta blockers. Okay. Now, of the nitrates, there are 2 different types of nitrates that are recommended. The first one is sodium what? Sodium nitroprusside, good. Also known as Nitrate. How is this given? How do we give sodium nitroprusside? It is a continuous infusion, so it's given as a drip. Okay? You guys okay with that? The thing you want to know about nitrite drips, they are potent okay, so vein, and artery dilators. So they're potent venous and arterial dilators. You guys okay with that? Very potent, very rapid acting. Okay? What is the major risk associated? Well, what are some major risks associated with sodium nitroprusside? Say it again. Cyanide. Sodium nitroprusside is metabolized into cyanide. Good. Especially at high doses. Okay? So cyanide toxicity can be a problem with this. And because it is so potent, you can have a precipitous decrease in blood pressure. So how are we going to titrate nitrite? Very slow, careful, methodical titration. Okay? Make sense? Yes. Absolutely a pump. Okay? In fact, not only is it suggested, it is required that you run a pump with this, but it is suggested that the patient has an arterial line placed in and the blood pressure is invasively monitored. So we know the blood pressure beat by beat, which means that for a standard paramedic, this may be something that you want to be very careful about transporting somebody on. Okay? Okay. Does that kind of make sense? Yeah. How do you treat that? Hydroxycobalamin. Yeah. Yes. Yeah.
It just doesn't seem like a good option.
It doesn't seem like a good option, but say transporting somebody and you noticed.
Right. Well, it's a major pitfall, but sodium nitroprusside is very effective, too. Right? It's very effective, and it's not like everybody that gets this is going to get cyanide poisoning, right? It's a pitfall, just like torsades and amiodarone, right? It's a pitfall. So you've got to kind of have to do that calculus in your head. You have to make that decision, risk-benefit analysis there. You know? But it is something you definitely need to be aware of. And the other thing you need to be aware of with nitrite is it is photosensitive. What does that mean? Yeah, it breaks down in light. So you need to cover it. Yeah, in fact, the nitrite comes, the nitrite, when you mix it, it actually comes with a foil covering. And you actually cover the bag with the foil after you mix it to prevent light from hitting the bag. Yeah, particularly ultraviolet lights, it breaks down really quickly. Yeah. So it's a tricky one. Are you guys okay with that? The dose, guess what? I would expect for you guys to look it up. All right. There is a nice little table in your book, though. And if you look at it, it's a very small dose. Micrograms per kilogram per minute, right? Start low and cautiously titrate up. You guys okay with that? That's one option. What's another nitrate that may be helpful? Hey, nitroglycerin, good. Okay, nitroglycerin. Now, does nitroglycerin, we're talking about a drip here, not, okay. This would not be somebody you'd want to give 400 micrograms to, like a STEMI, right? You know, because if you do precipitously impact their blood pressure, okay, once you give the nitro, that's it, right? You got to deal with what you got to deal with, okay? So we got to give this a drip. How does it work? Is it yeah, so it is primarily venous, right? Its effects are primarily preload, right? Whereas sodium nitroprusside also affects afterload, right? Okay? The thing nitro can do is any drug that decreases preload, okay, is also potentially going to cause tachycardia. This is sometimes known as a reflex tachycardia. When you drop preload, the heart's like, oh, what's going on here? I'm not getting preload, and then the rate will increase, right? So you can get a reflex tachycardia that will develop. Yeah, the heart's going to increase its rate. It's like, oh, what the hell's going on here? Remember, we saw this also with the dihydropyridine calcium channel blockers. If you give somebody a dihydropyridine, what are some examples of dihydropyridines? Oh man. Nifedipine or Procardia? There you go, yeah. So like nifedipine, Procardia, will also do the same. Can cause a reflex tachycardia. Okay, you guys okay with that? All right. Where do we start our drip off here? You guys should know this in a little more detail. What's our starting point for our nitro drip? Yeah, 5 micrograms per minute. This is a non-weight-based infusion. Okay, the Nitrate is weight-based. This is non-weight-based. And with a standard mix, okay, 3 milliliters per hour or 3 drops per minute, because if you use 60 drop tubing, drops per minute is milliliters per hour, right? Equals 5 micrograms per minute using a standard drip. Okay, so you titrate up in 5s. Okay, so 3 milliliters per hour is 5 mics a minute. 6 milliliters per hour would be 10. 9 would be 15. 12 would be 20, so on and so forth. That makes sense? And a standard mix, I believe, is 25 milligrams in 250, right? That's a standard mix for nitroglycerin. Even I have to look it up, but I think that's standard. It's your standard mix. 250. You better double check me on that though, but I believe that's a standard mix. Yeah. Some people will mix like 50 and 250, but I just kind of recommend your standard. What's that? 25 and 250. Yeah. Yeah. All right. You guys okay with that? Yeah. D5. Well, D5W really, if you have it. Yeah. Okay. So when we talk about beta blockers, is that all beta blockers, or is there a specific beta blocker that you think would be more appropriate? Huh? Why would Labetalol be the better choice? What's the other name for Labetalol? What's a trade name for Labetalol? Huh? Say it again? What? Low pressor? Yep, there you go, low pressor. Good. Excellent. All right. Why would Labetalol be the choice here? It's actually not. Labetalol is, there you go. It is a mixed, good. It is a mixed alpha 1, beta 1, and unfortunately there's some beta 2 crossover as well, but it's the alpha 1, beta 1 effects that we're interested in. So it's a mixed alpha beta blocker. So it's going to cause some vasodilation in addition to its impact on the heart. Okay? How do we give Labetalol? There are 2 ways we can give it. We can give it slow, good, slow IV push, or we can give it via drip. Okay. Yeah. So if we give it slow IV push, what I recommend is starting at 10 to 20 milligrams. And you're talking over 5 minutes. Very slow push, right? Over 5 minutes. And then you reassess the patient. If that doesn't work, what is generally recommended is you double the dose. So let's say I give 10 milligrams. It doesn't work, then what do I do? And that doesn't work, then what do I do? Okay, good. You guys see how that works? And you double the dose every time. Give it very slow, and you just do that to effect. You guys okay with that? That makes sense? I believe the maximum is somewhere around 300 milligrams or something like that, right? Total of 300. Yeah. 300, yeah. You can also mix it. You can also take that labetalol and you can mix it. What I tend to do, and your guide may be different, but what I've done in the past is I'll mix 100 milligrams in 100 milliliters and just make a 1-to-1 drip. And what they recommend is starting at about 0.5 to 2 milligrams a minute is what they recommend starting, and then you just slowly titrate up from there. So 0.5 to 2 milligrams per minute, which would be what?
0.5 to 30 drips.
Well, if it's 1 milligram and 1 milliliter, that would be there you go, 30 a minute.
30 drips.
Good, which would be 30 milliliters per hour. Good, you guys are all over this. Yeah. You guys okay with that? Now, I'm just going to throw this in for the sake of completeness, but if we're talking about toxemia of pregnancy, eclampsia, preeclampsia, etc., what medication is recommended there? And again, this is just for the sake of completion. We'll talk about pregnancy in a lot more detail later on. What drug, medication for toxemia of pregnancy? Throw this in the back of your mind. Yeah, magnesium sulfate is going to be your recommended go-to drug there. You guys okay with that? Again, we're not talking about pregnancy today, but I figured it would be good to throw that in for the sake of completion. And then what I want to do is I just want to throw out a question. What other agents do you think might be useful? Just off the top of your head. We've already talked about them. I've mentioned them. I'm sorry, what? I can't hear. I'm so sorry.
The beta blocker that you can only use in ICU.
Oh, there you go. Esmolol. Okay, so maybe some other beta blockers. What's the problem with esmolol? Is it selective or non-selective? Selective, yeah. So any of the selective beta blockers are just going to work on the heart. Yeah, and it's not necessarily going to work on. And are you guys familiar with this term, PV or SVR? Have you guys ever heard of that term, SVR? That's systemic vascular resistance. And if systemic vascular resistance is my problem, right? I have really sclerotic vessels, I'm overweight, and I've got a lot of them. The resistance is really high. Are beta blockers, cardioselective beta blockers, going to affect those vessels at all? They're really not, are they? So using cardioselective beta blockers, you're kind of neglecting the blood vessels. So when it comes to choosing agents, you want to go with something that's going to have some effect on blood vessels, or ideally you would like to cause some dilation to help decrease the blood pressure. Can you think of a class of drugs that would do that? Okay, there are some alpha-1 agents. They're not within our protocols or guidelines, though. Like phentolamine is an alpha-1 blocker. Could be an option. Coincidentally, now that you mention it, this is a good thing to bring up. When talking about phentolamine specifically, this is something you'll want to put on your drug cards. If you have infiltration, if a vasopressor infiltrates, what can that cause? If epinephrine or norepinephrine infiltrates into your arm. Cause necrosis, right? Because it can cause those vessels to clamp down due to the alpha effects, decrease circulation to that area, and then you can cause necrosis. The antidote to that is actually injecting phentolamine, which is an alpha blocker, into that area where that infiltration occurred. So that's something that that's something you might want to throw on your drug cards there for your vasopressors, specifically things like dopamine, epinephrine, norepinephrine, neosynephrine, anything that has an alpha effect. Phentolamine might reverse that and prevent necrosis. Yep. Yep. Better. Yep. Gotta tell them. Huh? Propranolol maybe, but again, it's a selective, right? Or it's but it doesn't affect alpha, does it? It's just beta 1 and beta 2. So all your beta blockers, with the exception of labetalol, don't have alpha 1 coverage for the most part, right? So that's something you want to think about. I was wondering if anybody was thinking about calcium channel blockers, right? Why not? What do you guys think? Calcium channel blockers, CCBs. What do you think there? Well, we talked about dihydropyridines, right? Dihydropyridines are highly specific to what? What kinds of tissues? They're highly specific to L-type calcium channels in. Remember, we just talked about these things like procardia or nifedipine. Vessels, right? Your dihydropyridine calcium channel blockers primarily affect blood vessels, right? They're highly specific to vascular smooth muscle. Okay? Well, that's kind of cool, but then we don't have the heart side of the equation covered. So what might another option be? Well, a non-dihydropyridine, right? And how many general types of non-dihydropyridine calcium channel blockers do we have? 2, right? We have the benzothiazepines and the phenylalkylamines, right? The phenylalkylamines include things like verapamil or Kalan, right? And what are they specific to? Cardiac tissue. So then you're running into the same problem as a beta blocker, right? But what about your benzothiazepines like diltiazem or cardizem or not? Yeah, diltiazem would be the major example there. That affects both cardiac and smooth muscle. Good option, huh? What do you think? What do you guys think? Good option? Yeah, at face value, it seems like a good option, but what we found is that some of these other drugs are rather unpredictable. They're rather unpredictable, and so as a rule of thumb, we don't generally use them, just because it's harder to predict how your patient's going to respond to them. Does that kind of make sense? So that's why, and I believe your book also and there's like a nice little table there that gives you a table and the major side effects and where they work and their doses. And it should talk about nitrite, nitro, and labetalol as well. But I figured a discussion around calcium channel blockers and other things would not be bad anyway. Does that make sense? And hopefully it makes sense why I actually talked about calcium channel blockers in so much detail earlier. It's kind of like, oh, okay, now we can start making connections, right? You guys okay with that? We have some brain draining going on now? A little bit? All right. Okay, so you guys okay with that? Now again, is this something that we're going to do a whole lot of? Not really. Okay, not really. This may happen in the hospital, but typically, if we can get away with it, we would prefer to orally treat people. Like to get them on an oral medication, get them on an ACE inhibitor or something like that, and gradually get their blood pressure under control. And it's only when we have a hypertensive emergency that we would be more aggressive like this. You guys okay with that? Okay, cool.